Okay, I'd like to welcome Mark Radford up to the stage, please. Mark is currently, I'm forgetting your professor, Mark Radford. Currently Director of Nursing at NHS Improvement and has been Chief Nurse at a local university teaching hospital.
Just down the road, Team Coventry. Are you in the audience?
Yeah.
So I embarrass them? Yeah, good.
Thank you, Mark.
Brilliant. So thank you so much for the opportunity to come and speak at your conference. I never resist temptation to come and speak to the tissue viability community because you are always so enthusiastic about driving improvements through in terms of improving care for our patients, whether they're in hospital or different community settings. I'm here on behalf of NHS Improvement, but my boss, Ruth May, none of you will need an introduction in terms of her personal commitment in terms of improving outcomes in relation to pressure ulcers. So today's talk really is a whistle-stop tour through some of the sort of national programmes that are going on, both in terms of Stop the Pressure and also React to Red, and how we're taking those forward and dealing with some of the challenges in terms of making further improvements within the system. But it's important to reflect on why this is important to me personally. When I first became a senior nurse within an organisation, I think it was around about 2 weeks, I was asked to see Robert. It's not his real name. It's actually his brother who asked me to come and see him. And he had quite a challenging experience in relation to his care. He was admitted to hospital. We had delays in terms of his pressure area care assessment, delays in getting equipment to him, and poor documentation, poor communication with the family. And I went to visit him actually in his home. He couldn't get out of his home. He was immobile due to the fact that he was in a wheelchair because he suffered a grade 3 pressure ulcer and actually ended up a grade 4 that resulted in an amputation. He was having a lot of nursing home care, and I went to see him and his family, and it was one of the most humbling experiences that I've had. And we've all got memories of patients in our mind and families that we will always draw upon and remember, why do we want to do what we want to do, making improvements or being a nurse. And it has always stuck with me, that family, about how we didn't wrap around the right care and support in terms of that family and truly understood his condition to really give him the very, very best of care. He had the most wonderful family, and since I made that connection over 10 years ago, I've remained in touch, actually, with that family, and I get holiday snaps from them. But sadly, in the last 6 months, I've heard that he passed away, not as a result of things. And they sent me a lovely, lovely letter after he passed away, highlighting what a change there was within the organisation that I worked in terms of the approach to pressure area care, and how they felt that the experience that he went through, although was sad, was actually part of the sort of journey that we'd gone on as an organisation to make changes in relation to pressure area care. So it's really, really important to never lose sight of the fact that I'm going to talk a lot of numbers and stuff like this, and like Joe, I'm really into my data around these sorts of things. But actually, behind all of that sits a story, sits a personal journey, a family, a community, and a patient or a service user that will have gone through this. So always remember that in terms of how we're taking forward any improvements. About this actually means a lot to people, lots to you, but also to lots to our communities and their family. Now, I don't need to tell you, you are an expert audience. You know the challenges faced in relation to the costs of both clinical harms, as well as also the avoidable costs in terms of finances. You know, we are going through a tough financial environment. And one of the things that's really important to highlight is that all of the impacts that you make out in practice are making an impact in terms of clinical outcomes, reducing length of stay, and also reducing costs in terms of doing that. And one of the things I often come across, it's really important, and my plea to tissue viability community is really truly understand the detail and the data behind what you deliver, because actually that's where preventative funding and investment comes from in terms of your organisations, in terms of the effects you have in terms of improving those outcomes. The Stop the Pressure programme was obviously kicked off as an ambition back in 2012, and it was there designed to deliver a significant culture shift in our approach to tissue viability. But it was an open door. I met many tissue viability experts up and down the country who were all champing at the bit, really, to have a programme that supported, raised awareness of this as an issue, but also in terms of raised the profile of the tissue viability community in terms of the impacts that they were having. It was a really ambitious programme. I remember when I sat down with my senior nursing team and I said, do you know, I want to eliminate all pressure ulcers in my organisation. I can remember Gillian now sitting at me with taking her glasses off at me and saying, you really, really think that we can do that? And actually, I believe we could. But actually what we needed is focus and energy behind that to ensure that we were able to deliver those outcomes. But it was also about making sure that we really harness the energy of our frontline staff. People often used to say to me when I was chief nurse in Coventry, they used to say to me, well, you know, you've had great results, you've made massive reductions, and we did. And they would say to me, but you must have like a massive tissue viability team. And I would always say to them that I had 2,800 tissue viability nurses. And they would go, really? How could you have so many? And I said, because every single member of our clinical staff is focused in on tissue viability. Yet I had the most amazing team of practitioners who worked collaboratively across Coventry and Warwickshire, working with the community setting, but there were only 3 of them. But they were fabulous in harnessing that energy and driving for improvements. But it was also, for me, really important that we engaged our community and our patients. So they truly understand. I remember I came into the car park one day and there was leaflets being ticketed on the cars in the car parks. And I was thinking, oh gosh, what's that? I bet the estates team are going to have something to say about that. So I went over and picked one up and it was actually React to Red. And I went, no, it's all fine, leave it, carry on, excellent. But it was about trying to engage our community to really truly understand and get them to start thinking about pressure area care. NHS Improvement, we haven't been around that long actually. We're relatively new, we've been around about a year, but we brought together lots of different parts of the NHS around patient safety, around improving quality. But what's really important is quality of care is central to our objectives. And when Ruth and I started discussing about what the quality improvement programme will look like for NHS Improvement, we chose 2. One was obviously pressure area care. And the other was falls. And we believe that those are the 2 programmes that we are launching into the system to be able to support improvements that we think demonstrate the value of tissue viability community, nurses, midwives and others up and down the country, and the outcomes that they deliver for their patients. So the National Stop the Pressure team, obviously Ruth May is Executive Director of Nursing for NHS Improvement. There's myself and Jenny Hall is the Nursing Advisor for the programme. We're delighted that we've also got somebody you'll be familiar with, Jackie Fletcher, who's working with us as a professional advisor and support in terms of developing the programme. But Ruth, if she was here today, would give, again, the same sort of commitment. You know, our ambition is to continue to drive further improvements in reducing a significant harm for patients in our NHS. And we will do everything we can to support organisations through the Stop the Pressure programme to be able to continue to make those sorts of improvements, highlight the best practice, and where we've got challenge, make further improvements. But we have done a great deal. So if we look at the improvements that we've seen broadly nationally around pressure ulcer settings, we've actually seen quite a significant reduction. This is national data, but the issue is we actually see some quite significant variation across the country. So different regions and different health communities have had sort of different responses. However, that's plateaued really in the last year or so. And actually some of the most recent data has suggested that there may have been a slight increase over the last 3 or 4 months in relation to reportable pressure care. We also, again, have seen similar experiences in non-clinical settings, non-acute settings. But one of the challenges that I'm starting to see emerge from the data, and you'll be familiar with this as practitioners yourself, is those patients who are not known to either health or social care. And that's a real challenge for us. And that's where the partnership between the Stop the Pressure programme and also in relation to React to Red works really well. And people often ask me about, why have we got two? Well, Stop the Pressure is very much around supporting providers. So that's the 240 plus individual provider organisations. But we work directly with NHS England on the React to Red programme, which supports systems, which supports community, about social care, about nursing homes. Because actually, providers, we're not an island. All of our patients flow in and out of our organisations. We share pathways, we share care with lots of other parts of the system. So it's important that we have those two things knitted together, because actually it's that combined effect that delivers the most significant outcomes for patients. Like I said, having analysed the data a little bit, and I haven't applied any statistical test to this. This is just Mark Radford's stand at the back of the room, look at it test. But actually, yes, the improvements have been made quite significantly since 2012. That's plateaued really in the last 18 months. And the most recent trend has started to see a slight increase. And the questions for me, is that normal variation or is that going to be a continuing trend? And actually, that's what we're looking through the collaboratives as part of Stop the Pressure to really truly understand what potentially is driving that and whether or not further improvements can be made. But you've talked a lot today about variation. We still find significant variation. So this is a funnel plot in relation to harms per 1,000 cases based on the numbers and the sizes of different organisations. And we still see huge variation in terms of harm outcomes associated with pressure damage. So we do have so much more to do. On an international basis for our outcomes are pretty good, but we do believe that through concerted work through Stop the Pressure and React to Red that we'll be able to drive further improvements in terms of outcomes. So our ambition for 2016-17 for Stop the Pressure remains. We still are committed to be able to develop the programme to support the culture shift and supporting that, deliver outcomes for our patients and their communities, but also provide focused support. And NHSI's role will be there to support organisations through the collaboratives that have been initiated over the last couple of months to be able to support that. So there are a number of key programmes of work to reduce pressure damage. We're obviously linked in with NHS England and the React to Red campaign, which has been led by a lot of work through the North region. Obviously commissioning research and use of evidence-based to support, as well as also the Allied Health Networks, NHSI Stop the Pressure programme, and obviously our links directly into social services through local NHS projects. So bringing together the whole programme is very much around driving improvements in individual sectors, but that marginal gains of making improvements in one part, linking in with others to be able to give ourselves bigger improvement gains. But we've got a number of challenges that we've been working through. So one of the things that I've asked Jackie to do initially as part of the programme is to sort out some of the reporting. I often speak to tissue viability practitioners and directors of nursing who go, well, I'll be honest, there's no consistency. People are using one measure and another measure and nobody's able to benchmark. So the measurement group, as we've called them, we didn't take long to come up with that title, to be fair, but they've gone away and are actually utilising the evidence base to come up with a new strategy in relation to reporting and measurement that we will do nationally so people are able to benchmark appropriately. Interesting, some of the information coming out, I'm not speaking out of school, is the classification between avoidable and unavoidable. People are kind of unhappy about that. They want to see them all as one now. So I think there's some really interesting challenge and debate coming out of that measurements group, but we'll then be able to clarify the appropriate use of different types of tools, whether it's safety thermometer, STICE, NRLS. So again, we've got some consistency in the reporting method. We've also got huge amounts of inconsistency in variations in practice. So even when we are working with individual organisations, we have very simple measures that we know work are being inconsistently applied to different organisations. So part of the collaborative, we're again working with those best organisations, taking the 10 very best and buddying them with those that are finding things a little bit more challenging. So they're able to learn from other organisations about how those improvements work. But it is going to be about reducing variation, because actually that's the problem here, is that an organisation gets it right for a period of time and then variation either creeps in or they've got variation in the standards of clinical practice and how they're applied. I get the debate. People often say to me, "Oh, I'm in safety thermometer. It's a prevalence study. It's not incidence. And why are we doing this?" And all this. At the current time, it's the only national standard we've got because all of the other incident reporting systems we've got are slightly inconsistent in their approach. However, we are working with HALO, which is the organisation that designed safety thermometer, alongside Jackie and her work in measurements to refine this and agree appropriate standards and monitoring to this. Because actually, I think it still is a really valuable tool that looks at harm. What we need to do is be able to do two things. One, get everybody to the same level in terms of reporting, so you're confident in the data in terms of being able to benchmark. The second thing is get everybody up to incident reporting to the same level, and that's a much, much longer piece of work. We still have some organisations who just use patient safety thermometer alone and don't report tissue viability issues through an incident reporting system consistently. So we need to get everybody into the same space, but in that time we need to make what we've got better. We've also got, obviously, clearly more work to do in terms of making improvements around pressure ulcer management, and part of the programme is obviously clearly linked into delivering those. So our call to action is we've started off the improvement work with the measurement teams. We've also got the National Steering Group, which is chaired by the Director of Nursing from Derby Royal Infirmary, has started out with a programme. The expressions of interest have gone out to the organisations to be part of the collaborative, which will be starting up just after Easter and into the early summer. We will use the same sorts of methodologies in terms of rapid collaborative improvement, but one of the key things is we will be doing is providing a lot of peer support. I won't be, because I'm not an expert in tissue viability, but actually utilising the very best in the NHS to go and support organisations directly in terms of making those improvements. But clearly linking in with the React to Red programme, because actually it's sometimes about a system. It's not just about the hospital. It actually might be also about the how the system is playing. There's a little orange light come on, and I've been told that means you've got, is that 5 minutes? It goes flashing red. I'm not sure what happens at that point. I get hoiked off stage, or I'm looking around here to see if there's like a trap door that's going to come out. Anyway, but better crack on. We want to harness the energy of doing this. We've set up the programme deliberately to gain frontline staff involvement in the programme and continue to do that. So our plans for this year, because of obviously the changes in the national architecture, we are revising the approach nationally in relation to consistencies of practice, so working with tissue viability community to do that, driving improvement through the providers using the collaborative methodology, very much targeting variations in clinical practice, and that is going to be our real feature, and using peer support to be able to do that. Revise and address all of the issues we've got around the national audit tools associated with pressure damage, and make sure that they are set and they're doing the right things, but also making sure that we've got really clear educational process both in pre and post-reg to ensure that we've got tissue viability and wound care and other types of clinical knowledge embedded directly within programmes, so working with the Council of Deans and others to be able to do that. And something that's really important to me and others is actually developing materials for patients. We've got the Stop the Pressure website where there are lots of materials available, but we're looking at other national campaigns. In fact, one of the suggestions is, could we get a tissue viability story on Coronation Street? That's a really big ask, but we'll give it a go. But again, we're trying to look really creatively about opportunities to raise the public awareness about how we might go about that, and our continued support in terms of innovation and research. You can become involved, so your organisations will be part of this. It's open to all health professionals. That's really important to me. Allied health professions, I want pharmacists involved, I want doctors involved, I want obviously nurses, midwives, everybody. I want to see their expertise shared as part of this. We've started off the Task and Finish group. We've obviously revised the Stop the Pressure website, which is actually now become one of our change champions, so access that, which is really helpful. In your local areas, make sure that we're able to share your best practice in relation to innovation. So again, we can start putting that publicly on NHS Improvement website and through React to Red and Stop the Pressure about sharing best practice. And one of the key things for me is about reaching out into care homes, reaching out into your communities as part of the React to Red programme to be able to support that. So the red light hasn't come on, nor the flashing red light. And I don't know whether we've got time for maybe a couple of questions, Heidi. Is that okay? But thank you very much for your time this morning.
Has anybody got any questions for Mark?
This thing's really cool, isn't it, actually? We should have one for the remote at home.
Yeah, somebody at the back there. It's a long way to throw, Des.
So I have to press it. Yeah. Thank you very much for your presentation, Mark. I'm Melanie Stevens from the University of Salford. I just want to make a point about the Keep Moving logo and Stop the Pressure. Having worked with the Tissue Viability Society trustees writing their new seating guidelines and being involved with an occupational therapist and other service users, in particular from our listening event, the Keep Moving is actually from a clinician's point of view and actually doesn't take into consideration the service user, because if you remain seated for long periods of time, actually to use the word keep moving is an impossible task. Is it more about keep repositioning or changing the pressure underneath the buttocks or the seated area or the body surface area?
Obviously there's another initiative running at the moment which has started out of Brian Dolan, which is around NPJ paralysis, which is just also talking about sort of keep moving. You're right, clearly there are clinical circumstances where that level of mobility is not appropriate for a patient nor clinically required, or for them to be able to do that. I think the general sense of messages is around, for me, is around aiming to harness and energise patients. We particularly in the acute sector have a challenge around patients being sat for far too long when they don't need to be, and getting them up and a little bit more active. So I get the general message, but clearly there are circumstances that actually need to be, clinical staff need to be reminded of that not being the appropriate one.
I just think that it's not just in the acute sector. Having worked closely recently with housing associations, a lot of care is given in social care environments, and actually using terminology that's most appropriate for people who are support workers in that kind of setting. I'm sorry, I'm just trying to be a bit of a devil's advocate here for the service user opinion. Okay.
You're right. I think 99% of the message is about, I think the majority of patients aren't active enough. So we need to encourage both health professionals, carers and informal carers to be able to get people to be more active. But you're right, if we're not doing that correctly for certain clinical or social circumstances, that could be detrimental.
Okay, just one last question with Tina here.
Hello, Tina Chambers, Tissue Viability Nurse.
Hello, Tina.
Hello. Just one thing, well, it's sort of a question, but supports that. Obviously, working with the definitions group and Jackie in the measurement group, we are having planning a survey and a meeting, which actually we want everybody to be part of. So anybody that's actually here today, there will be a survey going out. The TV website will have information about it as well when it goes out, although hopefully you should get it via organisations and otherwise to do that. And then also on the 16th of May, and that's a provisional date at the moment because we haven't got a venue, but we're looking at the 16th of May as actually having a national consensus meeting. That again, we want as many people as possible to attend so that everybody feels they've got some part of the process. And understanding about how we take measurement and the definitions of pressure ulcers forward.
Fantastic. So the short answer is, Tina's sat in row 2, second chair on the left. Come and grab her after this session to be involved. If not, please, you're welcome to email me. But there's a huge amount of work currently going on. And the collaborative dates, the kick-off dates have been set now, but I can't remember which ones they are, but they're slightly later than May, I think. So, but the measurement group clearly have got some asks of you in the audience. So thank you very much, Tina.
Thank you, Mark.